We have some great information lined up for you today. First, I want to go over some general housekeeping rules just for our webinar and standard practice. I want to remind everyone if they can please place your line on mute during the webinar and also avoid placing your phone on hold. This will eliminate any distractions during the webinar. Also, if you have any general questions, if you take a look at your toolbar on the right-hand side of your screen, you'll see a chat box below. You can type any questions in and our webinar staff will be happy to help you. Also, at the end, we are going to be taking questions. To do so, at the end of the webinar, we'll ask you to raise your hand. You'll also see that feature on your toolbar. And what we'll do is we'll go in alphabetical order and unmute your line once you've raised your hand. If you have any technical issues, you can contact GoToWebinar. I'd encourage you to write this number down. It's 855-202-7959. Again, that's the GoToWebinar Technical Assistance line, 855-202-7959. Now I'd like to go ahead and introduce today's presenters. We have three great presenters for you. We have Glen Fewkes, and Glen is a Senior Legislative Representative in the Government Affairs Department at AARP's National Office. Since joining AARP in 2011, Glen has worked with AARP state offices and other stakeholders across the country to develop legislation and policy in the areas of family caregiving, long-term services, and supports the implementation of the Affordable Care Act. Glen is a key author of the CARE Act, which helps family caregivers during the hospital discharge process and has been enacted in 31 states, including Virginia. Glen received his JD from the University of Pennsylvania Law School, where he was the editor-in-chief of the University of Pennsylvania Journal of Law and Social Change. Next, we have our very own Britt Rawlings. He's the Vice President and General Counsel for the Virginia Hospital and Healthcare Association. And finally, wrapping us up today is going to be Cherika Britt. Cherika is a Systems Clinical Education Manager at Sentara Healthcare. Her primary responsibilities include educational efforts to support system clinical initiatives, which offer the opportunity to work with interdisciplinary teams across the system, advocate for lifelong learning, and champion patient and family-focused projects and activities. In addition to her responsibilities as chair of the system-wide Patient and Family Education Council, she currently serves on the Clinical Performance Improvement Readmissions team as an education lead and a co-lead for the Patient and Caregiver Engagement Subteam. Now I'd like to turn the webinar over to Glen, who will start our presentation.
Thank you, and good afternoon, everyone. My name is Glen Fewkes. I'm a Senior Legislative Representative in AARP's Government Affairs Department based out of Washington, D.C. And I'm actually a Virginia resident myself as of about 5 years ago. I live up in Springfield, so I'm happy to be amongst fellow residents of our fair Commonwealth. Thanks especially to the Virginia Hospital and Healthcare Association for holding this webinar and allowing me to participate. I love having discussions like this with others who care about these issues and implement them on the ground. I am an occasional user of Virginia hospitals and healthcare services, so I greatly appreciate all of the incredible work that you all do. As I mentioned, I work in AARP's national office as part of the kind of internal policy and advocacy support team for our state offices. AARP has offices and advocacy staff in all 50 states, as well as D.C., Puerto Rico, and the Virgin Islands. And I personally have the pleasure of working very closely with AARP Virginia on issues regarding family caregiving, long-term services and supports, and health issues generally. So some of you may know Jim Dow, who is our state director here, and David DiBiase, our advocacy director, who both do great work along with their other staff based in Richmond and throughout the state. I'm really excited this afternoon because I get to talk with you about the Caregiver Advise, Record, and Enable Act, the CARE Act, which is a bill enacted in Virginia last year that helps family caregivers to be better involved and better prepared when their loved ones enter a hospital and as they transition home. I was involved with AARP Virginia and the Virginia Hospital and Healthcare Association and others as this bill was devised and passed last year, and I think it'll prove to be a great support for family caregivers in Virginia. Next slide, please. I hope that in my few minutes on this webinar I can give a bit of a background of where this law came from and why we feel it's so important in the state. First, just to lay a foundation, AARP's most recent estimates are that there are 40 million family caregivers in the country who provide 37 billion hours of care each year. And of course, sometimes we talk about family caregivers, and I'll use that term, but this really can mean a relative, a neighbor, a friend. It doesn't need to be a blood relation. Just in Virginia alone, there are over 1 million family caregivers who provide nearly 1 billion hours of care each year. And this can mean anything under the sun to help their loved ones live independently at home. So things like personal and intimate activities like bathing and dressing, helping to administer medication, to more common tasks like helping pay bills and managing finances or scheduling and accompanying someone to a doctor's appointment. Most of these things are done on an unpaid basis, but if you were to tally up the value of all of that care, it would be approximately $470 billion nationally and $11.8 billion in Virginia. So that's roughly the same as Walmart's annual sales worldwide. And more importantly, it's more than the country's entire Medicaid budget for the year. And truly, when we share these numbers with policymakers and the public, they are simply blown away at the scale, and it really puts into perspective the need to better support family caregivers. Next slide. Caregiving touches almost every family in the state in some way, and of course, it goes without saying that caregivers come in all stripes. But here's what we found about the average caregiver nationally. They're 49 years old. The majority, about 60%, are female, and it's usually a relative who they're caring for, especially parents and parents-in-law, who account for about half of all caregiving situations. And caregivers have been serving in this role for an average of 4 years, so it's not some short-term stint. On average, they're providing about 24.4 hours of care per week, so it's roughly like a part-time job. And then a whopping 23% provide more than 41 hours of care a week. And we know, of course, that others care for their loved ones 24 hours a day, 7 days a week. And on top of that huge responsibility, 6 in 10 caregivers report being employed outside the home, full or part-time in the past year. And 20% of the workforce serves as a caregiver at any given time. So even if you work at a pretty small place, chances are some of your coworkers are caregivers. And no doubt many of you on this webinar right now either are currently or recently have been caregivers. And I'll point out that the 2 women pictured here on this slide are Cherika and Evelyn of Roanoke. Cherika actually retired to provide full-time care to her mother, who was diagnosed with COPD after a stroke. Cherika was selected as part of AARP's Portraits of Care initiative to receive a hand-painted portrait that you see here. This portrait, along with others, caregivers of every other state, were displayed in the Senate building on Capitol Hill last year to recognize these amazing individuals and really shine a light on the work of family caregivers across the country. Next slide, please. A few years ago, AARP teamed up with the United Hospital Fund to do a study that we call Home Alone. And for the Home Alone report, AARP surveyed family caregivers across the country to get a feel for the type of help that they're providing. And what we found is that they're providing much more complex care than many had thought. So nearly half are performing some kind of medical or nursing tasks or medication management. Most didn't get any training to perform these tasks. Most of the care recipients, about 69%, didn't have home visits by a healthcare professional, so they're really doing these things on their own. And understandably, family caregivers that are performing these medical and nursing tasks were the most likely to feel stressed and worried about making a mistake, and that's certainly understandable. And more than half of the family caregivers reported feeling down or depressed or hopeless in the last 2 weeks. And more than a third reported fair or poor health themselves, so the caregiver's health is actually being affected. And as you might imagine, these negative impacts increased with the number of the care recipient's chronic conditions. So if you're caring for a more serious situation, the negative impacts increase on the caregiver. I don't think anything in this study was a huge surprise, but this study really got the ball rolling on this issue for AARP internally. Next slide. You see here the breakdown of some of the medical and nursing tasks being asked of caregivers. Up at the top, you see that the vast majority are performing medication management, whether that be oral, intravenous, or injectable meds. Almost half were administering 5 to 9 prescription medications a day. And this was reported to be difficult by family caregivers because it took so much time. There was a lot of anxiety about making a mistake, and some care recipients were uncooperative. This was absolutely the case in my own family. When my sister was a family caregiver for our grandmother who had late-stage Alzheimer's and was a fragile diabetic, my grandmother would vigorously fight the insulin shots. So it was a struggle just to get her the medication she needed to live. You see here going down the list, helping with assistive devices, preparing food for special diets, wound cares, meters and monitors, all very difficult tasks. One that I left off the bottom of the list because it wouldn't fit was operating medical equipment, things like mechanical ventilators and tube feeding systems. It really was a small percentage of caregivers, 14%, that were doing those. But of those, 49% reported it as hard to do. These family caregivers are performing tasks in a home environment that could challenge even professionals. Next slide. So this is clearly a need. So the question becomes, what can be done to help and when? And as you all know well, in the world of healthcare and long-term care, some of the most important times are when people are transitioning between settings and providers. So for example, between the ER and the normal hospital, or between the hospital and a nursing home, these are the key points when, if things don't go well, it can mean some pretty bad outcomes for the patients. So every couple of years, the Healthcare Intelligence Network does a survey of hospitals to ask them about care transitions. And one of these surveys just came out last year. When hospitals were asked what was the most critical transition of care, 50% said it was the transition from hospital to home. Now, whether that's to some kind of paid direct care help at home, or more often than not to unpaid family caregivers, far and away hospitals see this as the most important transition. So that's where we decided to focus, to improve this transition and to better prepare caregivers as they participate in this transition. Not all caregivers will get paid assistance at home. That's just a fact. And those who do get it might not get it for a few days. So no matter what happens down the road, caregivers need to be better prepared as their loved ones leave the hospital. And I recognize, of course, that in large part I'm preaching to the choir here. No doubt many hospitals in Virginia and around the country are doing an excellent job already involving family caregivers in the discharge process. And we've heard of some really great experiences of family caregivers in this area. The real point of the CARE Act effort is to build on existing practices and make this experience the norm across all hospitals. And as many of you have probably already noticed, the industry seems to be already moving in this direction. There are various transitional care demonstrations and models of care out there, and the newly proposed federal hospital discharge requirements do call for more involvement in family caregivers. And you'll hear from Sentara a little bit later about some of the good things that they're up to in this area. Next slide. In 2013, AARP put together a model bill that states could use as a basis to craft their own bills to help address this issue. And we call this model the CARE Act, the Caregiver Advise, Record, and Enable Act. And this is what Virginia used as the starting point for its bill. And truly, there's no point in doing any of this if there isn't buy-in at the state level. So AARP worked very closely with legislators, with VHHA, and others to make sure that Virginia pursued a version of this bill that makes sense for this state. And we really do appreciate the collaborative spirit from your organization. And in a minute, Brent will spend a bit more time talking about the details of the law, so I won't spend a lot of time on this, but the law does three simple things. When a patient is admitted, they're given the opportunity to designate a family caregiver and to have that person's information actually put into the patient's medical record. If the patient does choose to designate a caregiver, that person would then be contacted prior to discharging the patient. And finally, the caregiver is given a chance to consult about the discharge plan and to receive a demonstration of the specific follow-up care tasks that the caregiver is going to need to carry out at home, and to ask questions, get a chance to figure out about these tasks. The CARE Act passed unanimously in both chambers of the Virginia legislature and was signed by the governor in March of 2015 and became effective in July of 2015. Next slide. Virginia was actually the third state in the country to pass this kind of a bill after Oklahoma and New Jersey, and since that time there's really been a wave of enactments across the country. Currently there are 31 states or territories that have enacted a similar law, so these are in this map that you see on the slide, those are the red states with the little heart. And this map is actually already out of date because just recently the governors in Hawaii and Louisiana signed their bills. Alaska has also passed the law through their legislature, and we're waiting on the governor to sign that. The dark gray states on the slide here are the ones where the bill has been introduced and we're still working on it. And we hope a few more states may pass the bill before the year is done. Given that the CARE Act has only been in existence since 2014, we think this is a really good showing and a clear sign that this is needed. And on top of that, you take a look at the states here, the mix of states that have passed the CARE Act. This is clearly not a red or blue kind of an issue. This is a human issue that a lot of people can get behind. Next slide. Finally, just as a last word, the CARE Act is not the only thing we're working on at AARP to support family caregivers. Here's a list of a few things that AARP and others are pushing in states across the country, from workplace flexibilities to telehealth, guardianship issues, and many others. What we found is that caregiving policy issues are synergistic. So when you raise the profile of family caregivers and you're able to pass a bill in a particular state, it actually makes it easier to pass similar other measures in that state. These efforts are not in competition with each other. The CARE Act shows that there's an appetite for this here in Virginia, and hopefully this is just the start. Next slide. So thanks again for the chance to speak with you today. I look forward to the discussion, and thanks for all that you're doing to help family caregivers in Virginia. I'm going to turn it over now to Brent Rawlings, who's the VP and General Counsel for VHHA, and he's going to go over in a little more detail the legal and regulatory requirements surrounding the CARE Act and hospital discharge.
Thanks, Glenn, for that policy background. It was very helpful to set the stage. And good afternoon, everyone. I'm going to provide a quick overview of Virginia's CARE Act. I was involved in working on the law along with Glen and David DiBiase and others at AARP, so I have some familiarity with it. I'll provide background on how the law developed in Virginia and VHHA's approach to that proposed legislation. Then I'll just walk through briefly with you the statutory requirements in some detail, but not too much. I'm really just hoping to provide you all with a baseline understanding of the legal and regulatory requirements here in Virginia. Next slide, please. In May of 2014, VHHA was approached by Virginia AARP on the proposed CARE Act legislation. That's when we first found out about this initiative. And our starting point was to collaborate with AARP on exploring the policy issues and existing regulatory requirements that hospitals are subject to relating to discharge planning. Following this development period in January 2015, the bills were introduced in the General Assembly. We worked on further amendments to those bills, and they were subsequently passed in February 2015 by both the House and Senate, and as Glenn mentioned, that was pretty much a unanimous vote. And then they were signed into law by the governor in 2015. So in March of 2015. So in about a year's time, this initiative was put into law here in Virginia. Next slide, please. From a policy perspective, AARP and VHHA, we feel we're aligned on this issue. Generally speaking, both of our organizations supported measures to improve the patient experience. That certainly was our focus. VHHA's approach in working with AARP was to first look at existing requirements pertaining to discharge planning, mainly the Medicare conditions of participation, the Joint Commission standards, and existing state law. And we really wanted to ensure that any proposed legislative changes were not duplicative of laws already in place, but also to make sure that the stakeholders were aware of all of the various efforts going on in this area. Ultimately, we wanted to avoid creating additional regulatory burdens upon hospitals that really didn't result in any improvements to the patient experience. And I think where we ended up with the CARE Act strikes the right balance in that regard. Next slide, please. So simply speaking, the CARE Act applies to any facility licensed as a hospital. It's actually part of the licensure code in Virginia. It applies to all inpatients of the hospital as it's drafted. It became effective, as Glen mentioned, on July 1, 2015. The Virginia Department of Health had an opportunity to promulgate regulations on the statute. However, it ultimately determined that it was exempt or non-discretionary in the regulations, which basically means that the statute is more or less restated in the regulations without much embellishment. So there was not a extensive rulemaking process behind the statute in the regulations. So what you see in the code more or less reflects what is in the administrative code in the regulations today. Next slide, please. So this next slide shows, it breaks down the CARE Act statutory requirements, and this just gives you a basic overview. I'll delve into each one of these in a little more detail in a second here. But just walking through the chief components. One, the patient is given the opportunity to designate a caregiver. The second is there is an obligation on the hospital's behalf to provide notification of discharge and provision of the discharge plan to the caregiver. 3, there is the requirement to include patient-caregiver engagement in the discharge planning process. And then last 4, there is the added benefit of some legal protections for caregivers and hospitals that were built into the law. And next slide, please. And I'll walk through now each of these different components in a little further detail. As you'll notice on these slides, just by way of reference, I did include the statutory citation as well as the corresponding regulatory citation, so you'll have a crosswalk there to the statute and regulations. With respect to opportunity to designate a caregiver, each patient or his or her legal guardian is asked by the hospital to designate an individual, the caregiver, who will care for the patient in the residence following discharge. And note that that term residence is defined in the statute not to include basically patients going to a rehab facility, hospital, nursing home, assisted living facility, group home. It's intended to truly focus on those situations where the patient is returning to the residence and home-based care. Upon admission, the hospital is also required to record the caregiver information in the medical record, and the statute specifies what information should be included, the name, relationship, telephone, and address of the caregiver. And if ultimately, if the patient decides not to designate a caregiver, then there needs to be a statement about that included in the medical record too, that the patient failed or refused to designate a caregiver. And then there's also a provision in the law that specifies that the patient can change the caregiver at any time prior to discharge. And that information, if there is a change, must be changed in the medical record, including that the related contact information. Next slide, please. With respect to notification of the discharge, The hospital is required to notify the caregiver of the discharge prior to discharge, so that caregiver receives notification that the patient is going to be discharged and is scheduled for discharge. The hospital must also provide a copy of the discharge plan and instructions and information regarding any follow-up care the caregiver is appointed to provide. So that discharge plan would be provided to the caregiver at discharge. The law also specifies that the discharge plan must include certain information. Must include the name and contact information of the caregiver and a description of the follow-up care that caregiver is appointed to provide, as well as information about health care, long-term care, or other community services, community-based support services that are necessary for implementation of that patient's discharge plan. Finally, the law does specify that this is an existing practice anyway, but that the copy of the discharge plan must be included in the patient's medical record. So those are the notification and discharge plan requirements. Next slide, please. Another chief component of the law is the requirement to provide caregiver education. Prior to discharge, the hospital is obligated to provide the caregiver the opportunity for a demonstration of follow-up care tasks that the caregiver will provide to the patient under the discharge plan. Note here the use of the word opportunity. I think it is intended to contemplate that there are some instances where the caregiver may decline, or it may be that the specific follow-up care tasks are relatively straightforward and may decline for that purpose. Also, the education piece, this should include an opportunity for the caregiver to ask questions and follow up about those follow-up care tasks to make sure that they have a firm understanding of the follow-up care they are expected to provide. And that demonstration is also expected to be provided in a culturally competent manner and in the caregiver's native language. Next slide, please. Last but not least, as I mentioned, the law does include some additional legal protections for caregivers and hospitals. Specifically, the designation as caregiver does not create an obligation on the part of the caregiver regarding the provision of any follow-up care. Stated another way, the caregiver cannot be held liable for a failure to provide follow-up care. The law also does not create a private right of action against a hospital employee or contractors for failure to comply. Remember that this is part of the licensure code, and the Department of Health takes a different approach to provisions in the licensure code. It's not a private right of action. Also, no hospital employee or contractor may be held liable for civil damages or injuries resulting from any act of a caregiver related to the provision of or failure to provide follow-up care. And finally, the law does not interfere with any individual actions under a valid health care directive. It was intended to make sure that we preserve the provisions in the Health Care Directive Act. Next slide. So that is a summary of the Virginia Care Act, but before closing out on my piece, I did want to just point out, and Glen mentioned this previously, that there is additional work going on in this area at the federal level on discharge planning. So more change is coming. This slide shows a summary of proposed changes to the Medicare conditions of participation. Some of these do line up with the CARE Act, but just sort of a heads up, this proposed rule is out there. I don't know that there is, are there any immediate plans to finalize that, but it is in play. So with that background and an overview of Virginia's CARE Act, I'm going to turn it over to Cherika Britt to share with you how Sentara Healthcare has approached implementation of the CARE Act at their organization. Cherika?
All right. Well, thank you, Brent, and good afternoon, everyone. I really am pleased to be here with you today to talk about some of the measures Sentara Healthcare has put in place to ensure adherence to the Virginia CARE Act. I believe that I speak for all of Sentara in saying that although these efforts to designate and engage the caregiver is required, it's also the right thing to do. And it's totally aligned with our mission to improve health every day. So during the presentation, I'll share with you some of the measures we have in place. We'll talk a little bit about how we've enlisted the support of our patient and family advisory councils to kind of help us along the way. We'll talk about some opportunities for improvement we've identified, and also some tools and programs developed to kind of help us along the way and to prepare our staff. I'll also end by offering some considerations to be mindful of as we continue along the journey. Okay, next slide. So I'll start a little bit about, just to give you an overview of Sentara Healthcare. For more than a decade, Modern Healthcare magazine has ranked Sentara as one of the nation's top integrated healthcare systems. Our not-for-profit system proudly includes all of the services that you see listed. We also have a 3,800 provider medical staff and 4 medical groups, and we extend health insurance to over 445,000 people through Optima Health, which is our award-winning health plan. Next slide. So also want to give you a little bit of an overview of the Sentara Healthcare Clinical Performance Improvement Initiative. This initiative that was launched in January of 2015 is a multi-goal, system-wide effort to improve safety, outcomes, and also the patient experience at Sentara. Last year, we had some ambitious goals, and our achievements were very significant. And as a result of that, we continue to focus on clinical PI this year, 2016, with goals including reducing hospital readmissions, improving the appropriate utilization of hospice and palliative care, reducing the rate of hospital-acquired C. difficile infections, eliminating wrong events in the OR, IR, vascular, and cath labs, and also improving patient access. Next slide. So, as we stated on the previous slide, one of our 2016 Clinical Performance Improvement Initiatives is focused on reducing readmission. So our team, that's led by Dr. Paul Chittister, Vice President of Medical Affairs, Dr. Carl Hartman, who is Medical Director of Clinical Effectiveness, and also Mary Moran, who is the Vice President and Nurse Executive of Sentara Medical Group, recognizes that an important way to do this is by improving the way that we identify and engage caregivers to make sure that they have the help that they need when they get home. So the goal at Sentara is to streamline that process. We know that a critical component is to ensure we have effectively identified and adequately prepared caregivers with instructions and also the guidance for post-discharge care. And we know that in doing this, we not only provide high-quality care, but we also reduce the risk of complications that drive readmissions. Okay, next slide. Here what you see is a breakdown of our focused readmissions clinical PI goals. And with these goals, we've developed tactics to address our aim to reduce the 30-day readmission. So the first thing that you see highlighted here is engaging the patient and caregiver. But in addition to this, we also have identifying patients that may be discharged within the next couple of days to plan accordingly as a goal, and also ensuring patients have the medications they need and they know, what they're for. And in addition to that, ensuring that patients have a post-discharge follow-up appointment within 7 days. Next slide. So this brings us to the focus for today. Even though we know that measures to identify and engage the caregiver will help us to adhere to the Act, we also know that it will enable us to provide better communication for the patients and their caregivers about the plan and how they can, in essence, be a part of it. It will allow us to ensure patients have the help and support that they need for a successful recovery, identify any challenges that might prevent them from fully recovering, and also better explain all of the services and support that we can provide. Next slide. So this gets us to one of the most exciting and rewarding things that we've been able to do. early on, we knew that it was going to be essential that we ensure we have the voice of the patient and the caregiver at the table. So to get this perspective every step of the way, we enlisted the help of our patient and family advisory councils, which are active in most of our divisions, and what we continue to learn from them really is invaluable. What you see here is a listing of some initial questions that we have for them. Couple include what is their understanding of the role of the caregiver? Do they have any insights into barriers faced regarding the understanding of the post-hospital care? And also, what information do they need clear access to? So we continue to learn a lot from them. Some of the notable themes derived from their answers include the importance of having access to a live person to talk to following transition to home, the need to know the essential things that they need to report to the doctor, also the need to pace education sessions. And that really does highlight the importance of the timing of education and not overwhelming patients and caregivers with too much information at one time. And also they certainly had things to say regarding the importance of having follow-up appointments scheduled before they leave the hospital. Next slide. So in working to identify what key tactics to employ, we knew that there was a need to examine our existing workflows just to see how closely we aligned with the new standards. What we found is that we had some pretty impressive measures already in place. And with the help of our integrated care management team, they were really leading that charge. However, there was an opportunity for us to be more intentional and focus on the goals to ensure that we engage the caregiver, to be standardized, or to ensure that the solutions were hardwired system-wide, to be consistent by doing it the established right way every single time, and also to be outcome-oriented by having our goals in clear sight and keeping track of our progress and measuring our success. Okay, next slide. So with due diligence in analyzing the current state and identifying those opportunities for improvement, our team arrived at key tactics that you see here. So in identifying the patient caregiver, we reviewed the role and the expectations of the caregiver. We know that that is essential. We also created a Preparing You for Leaving the Hospital video and brochure that we'll talk a little bit more about. And we set up a process to ensure ability to not only document, but view for all to see the name and contact information for the caregiver in the electronic medical record. We conduct a transition planning initial assessment where verification of the caregiver information is done, as well as verifying that that caregiver is not only willing, but capable of fulfilling the role, and to identify any anticipated transition planning education needs. Measures to engage the caregiver in the transition planning is key, and we do this by performing a patient and caregiver learning needs assessment and providing education at the appropriate time and checking back for their understanding. We also work to identify needed resources as well as follow-up phone calls and appointments that are needed. We also recognize the importance of reviewing the transition instructions and want to arm our patients and caregivers with information on those problems that warrant reporting to someone and exactly who is that person they need to report to. Also ensuring that they are aware of the follow-up plan and that we go over options with them regarding the filling of their prescriptions prior to transition. Okay, next slide. So in support of these goals, we have developed several tools and programs, and I would like to review a few of them with you today. The first thing that you see is the Preparing You for Leaving the Hospital video and brochure. Okay, so in that video, the information is also reinforced in the brochure, and it covers things like what is a patient caregiver and how can they help, what questions to ask during the stay, thoughts on managing medications, and also follow-up care. And it is now an expectation that every patient and caregiver view that video in the early days of admission, and ideally at least one more time before the anticipated transition date approaches. Also want to talk to you a little bit about our Sentara to Home program. We are very excited about that program and have received lots of positive feedback from our patients as well. So with the program, there is the ability to purchase medicines, home medical equipment, and other healthcare needs, all before the patient leaves the hospital. The last image that you see is our transition follow-up phone call flyer. So the follow-up phone call is an automated system that contacts the patient at home, asks them a few important questions about their health and progress. Those answers are then reviewed, and based on the answers, a Sentara clinician may call the patient to offer help and instructions. Next slide. So we recognized that in order for the plan that we put in place to be successful, there was going to be a need for us to have a learning plan that engaged all members of the team and tailored additional learning to what was needed for hospital staff depending on their role. So we identified communication and training specific to the staff and also the best methods to deliver the learning. We started with the general awareness that was for all staff. We drilled down to that training that was appropriate for clinical staff and physicians in all of our divisions. And then we drilled further down to that training specific to inpatient nurses and care managers. You'll also see that we listed materials and resources that would aid in the learning, and we created a learning module for all staff to view. Next slide. So this gets us to the high-level graphic that you see regarding the process, wherein the patient is asked to identify a caregiver. A risk is identified if the patient does not have a caregiver. The caregiver name and contact information is documented in the electronic medical record. The care manager verifies the information and ensures that the caregiver is willing and capable. The care team engages the patient caregiver throughout the stay and seeks every opportunity to keep informed and also educate in anticipation for return to home. The care team also informs the caregiver of the transition date, ensures that adequate resources are in place, and that it's a seamless transition. Our measures are ultimately that patients and caregivers understand that post-hospital plan, and we continue to promote the use of TeachBack and also track our HCAP scores to measure effectiveness. Next slide, please. So as we continue along this journey, there are several considerations that we want to be mindful of. The first is the importance of health literacy and our aim to ensure that educational materials are easy to understand. We also want to ensure that our materials are accessible in multiple languages and that we use provided tools for the hearing impaired. For our deaf and hard of hearing, blind, visually impaired patients, patients with low literacy or limited English proficiency, and that's not just for the patient but also for that caregiver. We use the Language Access Network to assist with that communication. And so what that resource does is it includes on-site interpreter services, document translation services, over-the-phone interpreter services, and also video relay interpreting. Next, I want to bring your attention to the importance of providing resources to support our caregivers, whether that be education, informing of support groups, or pointing them to appropriate online resources. Lastly, want to highlight the importance of setting up a process for continuous improvement. You know, things like ensuring that there's a process in place to track compliance with the documentation of the patient caregiver, you know, monitoring our patient satisfaction scores and making improvements as appropriate, and also monitoring to see if our efforts are ultimately having the ultimate impact, and that's reducing our readmission rate. Okay, next slide. So I want to thank you all very much for the opportunity to present our progress with efforts to support the Virginia CARE Act and really continue our mission to improve health every day. So with that, I will say thank you.
Thank you so much, Cherika, and the rest of our presenters, Glen and Brent, for that very meaningful presentation. At this time, I will ask that if you have a question, you use the icon in your panel to raise your hand. And I'll just wait for a few seconds to see if anyone has any questions. If you feel more comfortable, I also encourage you to write your question into the chat box at the bottom of your control panel. All right, and I see that we have a question from Brawin Harvey. I will unmute your line and you will be able to ask your question.
Hello.
Go ahead. Hi.
Hi. Thank you all for this presentation. I was just wondering, will this be available to us, the PowerPoint?
Yes, ma'am. This PowerPoint is being recorded, and it will be available via email following today's presentation. Also, VHHA will be featuring this on our website, so I would look in both of those places, and you'll be able to have that content.
Okay. And I did have a question for Ms. Britt. How much are your case managers involved in your process, or are they? Or is this just nursing totally involved?
Hi there. So I will say our integrated care managers are very much involved in this process. And honestly, we're early adopters. And really, I will say that a lot of the processes and everything that we have in place really started with some of the things that they identified, you know, a year or more ago that needed to be done. Again, I want to say that many of these things that are in place are really the right things to do. And our focus was more on, even though we had some of these things in place, we wanted to make sure that it was standardized, that it was consistent. So yes, I would say our integrated care management team is highly involved, as well as our inpatient nurses.
Okay, thank you.
Great. So I will go ahead and see what other questions we may have. It looks like Amy Mitchell submitted a question. Just give me one moment to pull it up. All right, just bear with me one moment, folks. All right, Amy, I'm not seeing your question. If you would like, I can unmute your line and you can go ahead and ask that question. Amy? All right, I'll go ahead and see if there are any more questions. We'll try and take one or two more. So we have a question from Kathy Miller. The question is, do you use a particular model for your care transitions interventions? I'm going to assume this might be for you as well, Cherika.
Hello there. I really can't right off the top think of a specific care management model that we use, although there may be one that the integrated care management system uses. I will say that one of the things that we are very good about is identifying external best practices, but also kind of looking internal to best practice and evidence that kind of helps us to drive some of the interventions that we put in place.
Great, thank you so much. And looking over some of the other questions, they are asking again about where this information will be following the presentation. As I said, VHHA will have this on our website. And I also encourage you to get in touch with a VHREF staff member, and we will be able to connect you with the speakers for today. But again, I want to thank all three of our presenters today for presenting such meaningful information. And at this point, the webinar will conclude. Thank you so much.